the neuropelviology. The neuropelviology, but through the story of the neuropelviology start maybe for 15, 20 years. At that time, I was in the University of Jena, and we started with, my teacher was Professor D'Argent. I learned the radical trachelectomy from D'Argent. And then we performed in Jena the radical hysterectomy. At that time, we saw that we are really able to improve the radicality of the procedure comparing to abdominal procedure. You see on the left such specimen after radical hysterectomy on vaginal roots. But what we saw at that time was that patient or the morbidity of our procedure increased. Patient had difficulty after the procedure with a libido. The patient have difficulty with bladder function, filling and voiding function with the rectum. So at that time we start with the idea maybe using the laparoscopy, because laparoscopy enable a magnification. We can use the magnification to expose better the nerves, to learn better the pelvic neuroanatomy. Here you see the first step in the field of the neuromodulation. I already stimulated the second sacral nerve root that induce a flexion of the tooth. Yes, and we start to learn better about the pelvic neuroanatomy. And what we learn is that we have a lot of nerve inside the pelvis. Some of nerves are going up to the brain, other nerves are going down to the pelvis. So when you have a pathology of the pelvic nerve, you will have a big amount of complaint. You will have a lot of pain. I remember that all pelvic nerves are involved in the vulva, the pudental nerve, the vulva, the perineal area, and the perianal area. So when you have a pathology of the pelvic nerves, the patient will develop vulvodynia, prostadynia in men, it's the same, coccygodynia, pudental pain, and of course deep back pain. So when a patient has back pain, it's not always a discus hernia or a pathology of the spinal cord. It could be also a pathology of the sciatic nerve or the sacral nerve root within the pelvic cavity. And when you have a lesion or disorder of the efferent fibers, the nerve going down, the patient will, when you have a decrease of the function of the nerve, the patient will develop chronic constipation, bladder retention, loss of sexuality, loss of erection. Ejaculation is the superior hypoglossal plexus behind or in front of the aorta, while the pudental nerve, the pelvic nerve are involved in the erection, so you have a loss of erection. When you have an hyperstimulation of the nerve, the patient will develop a bladder overactivity, or an overactivity of the rectum, or an overactivity of the sexuality. So the problem in the pelvis is for everybody the black box. I'm sure it's a black box for you. And it's also a black box for most of the neurologists. You have a lot of fibers. You have visceral nerve, you have somatic nerve, you have afferent fibers, you have efferent fibers, you have sympathetic, parasympathetic nerve. It's really difficult to understand all these pelvic nerve. It's a black box, and that's the reason why, but it's true, nobody is dealing really with the pathology of the pelvic nerves. If you answer neurosurgeon or neurologist, they are dealing with the brain, with the spinal cord, maybe some peripheral nerve, but not with the pelvic nerves. They have no approach, neither for clinical examination nor for neurophysiological examination. The neurosurgeon know only two approaches, coming from the back and coming from below. That's the reason they know only two things: spinal cord surgery, spinal cord neuromodulation, and surgery from the pudental nerve. But when you have a pathology of the pelvic nerve inside the pelvic bone, it's not possible for neurosurgeon to approach the nerve because they are coming from outside the nerve on the other side of the bone. And that's the reason why we develop the neuropelviology. Neuropelviology is a medicine of the nerve, pelviology inside the pelvis, the pelvic nerves. And the neuropelviology, the first you have to learn is the pelvic neuroanatomy. Without an exact knowledge in pelvic neuroanatomy, you have no chance to understand neuropelviology. Maybe you will be able to make some surgery on the sciatic nerve when you have an endometriosis, or maybe a neurolysis of the pudendal nerve. But the most important in neurology is not what you're doing, but the diagnosis. And if you want to have a proper diagnosis, you absolutely need a proper knowledge in pelvic neuroanatomy and neurofunctional anatomy. So you have to know exactly which nerve is involved in which function, afferent, sympathetic, parasympathetic function. The second is then to do the neuropelviological diagnosis, nothing to do with gynecology. Of course, we are using the gynecologist way for the diagnosis. We are using the vaginal or the rectal approach for palpation of the nerves. But the palpation is not forwards in direction of the uterus, but backwards in direction of the coccygeal bone. You will find the pudendal nerve and the sacral nerve roots at that area backwards. And then we are using a lot of neurologic way of diagnosis, but adapt to the pelvic nerves. It's not the same. And the third step in neuropelviology is then to start with different procedure, pelvic nerve sparing technique for radical hysterectomy. We are doing neurosurgery to the pelvic nerve, neurofunctional surgery, and under the neurofunctional surgery, we have the Lion procedure. So here, it was a patient with a stitch. The patient underwent a McCall procedure, hysterectomy with a McCall procedure. The colleague tried to fix everything very high by following the sacrouterine ligament, and he put a stitch on the second sacral nerve root. That is a sciatic pain, dorsally internal area of the legs, plus a dorsal pudental pain. Here it was a patient after an hematoma, retroperitoneal hematoma, secondary to a TFT procedure, and we had to perform here a neurolysis of the pudendal nerve and here of the sciatic nerves. Everybody heard from the Alcock canal, pudendal neuralgia is the same like Alcock canal. It's not true. The Alcock canal is just one region where you can have a lesion, an irritation of the pudendal nerve at the Alcock canal. But the most frequent etiology for irritation of the pudendal nerve is not at the level of the Alcock canal, but much more higher, inside the pelvic cavity. We are here above the pelvic floor. And here we already cut it here, the sacrospinous ligament, which was crossing over the pudendal nerve, and we carry on the dissection down. Here you have the Alcock canal. But the pathology was over, inside the pelvic, above the pelvic floor. So here, you know, you're a gynecologist, you know endometriosis. I remember for 15 years when I make my third lecture on endometriosis of the sciatic nerve, most of my colleagues say, well, Mr. Possover, you will see one or two such cases in the rest of your life. 2011, we had a paper from 113 cases of endometriosis of the sciatic nerve. We already made now a paper where we describe 46 patients where we perform a laparoscopic resection of the sciatic nerve, more than 30% of the sciatic nerve. Why we did it? Because most of the colleagues, when I saw my procedure here, I'm cutting the internal obturator's muscle because of an endometrioma. I always got the question, yeah, Mr. Possover, you're crazy. You have endometriosis of the sciatic nerve, you're cutting the nerve from a normal patient, you are making a patient sitting in a wheelchair. And my answer, what are you doing when you have an endometriosis of the rectum or the bladder? You're not cutting? Why not cutting in endometriosis of the sciatic nerve? It's the worst kind of endometriosis. Here you see an endometrioma inside the sciatic nerve and isolated. And when you have an infiltration of the sciatic nerve by deep endometriosis, I'm sorry, this part of the sciatic nerve is completely destroyed. you have to remove it. And you have to be radical, because there is no place for a second surgery in this area. When you go there, you have to be sure that you are able to treat the patient, to remove the endometriosis. Here you see the sciatic nerve on the left, and here we are cutting part of the sciatic nerve, and you see here chocolate fluid inside the sciatic nerve. And the last patient from this video will see it was such a resection for more than 50% of the sciatic nerve. And what we discover in this paper is, so far, you don't cut completely the sciatic nerve. When you have even just 5 or 10% rest of the sciatic nerve, it will be enough for the patient to recover a normal gait. But it takes time, 3 to 5 years with intensive training. Maybe we do the next. Also on the right, it was a huge endometriosis of the femoral nerve. You have here the left femoral nerve. Here you see we are cutting the sciatic nerve. That is the sciatic nerve, and we cut more or less 50% of the sciatic nerve. And here we cut also more or less 80% of the femoral nerve, and the patient now 4 or 5 years after the procedure have a normal gait. She has some hyperesthesia in the femoral dermatome. She has loss of patellar reflex, but she is able to walk with a normal gait. So that is your field. Now another field, the most frequent etiology for pathology or irritation of the pelvic nerves is a compression of the pelvic nerves by enlarged vessel. For example, when you remove the uterus, all the blood in the pelvis will have to go up by following pelvic sidewall vein. Or when patient underwent a stripping in the legs, patients who have varicose vein in the leg have varicose vein in the pelvis. And in 3 different areas, no time to explain how it's worked, but in 3 different areas in the pelvis, when the vein are pressing on the nerve, and on the other side of the nerve you have bone, or you are in a very narrow space, you will have a compression of the nerve. You can make the diagnosis with your fingers, and using your vaginal sonography, you will find exactly at the trigger point where you have your nerve, a varicose vein. And here it was a young patient with a compression here of the sciatic nerve by enlarged vein. So this patient had catamenial ischialgia and punental pain. So vulvodynia, perianal pain, coccygodynia, and ischialgia in the leg down every month during the men's bleeding, or in all situations that increase the blood pressure in the vein, whether like today, it's hot, it increases the blood pressure, or when the patient was sitting for a long time, it increased the pressure, or when she was coughing. All these situations increase the pressure and exercise pressure on the sciatic nerve and induce pain. Now we are completely in another field. It's really the field of the neurosurgery. Here we had a patient. It was a patient coming from Italy with a huge phenoma. We are here with the sciatic nerve. Here the red is the piriformis muscle. And you have here the lumbosacral trunk. This small nerve is the superior gluteal nerves. Here you have S2. And we have this schwannoma. And of course, neurosurgeons, what they can do, they cannot come from behind. They cannot destroy everything. So they send us a patient, and we did the surgery. Or in this patient, you saw on the picture, it was a very small schwannoma, but very painfully inside the second sacral nerve root. That is the second sacral nerve root. We use 3 millimeters instrument. And this patient has 2 sacral radiculopathy, is perianal burning pain, gluteal pain, and sciatic pain down to the feet. And we had to remove this schwannoma inside the sciatic, the sacral nerve root, and inside the pelvic. A neurosurgeon have no approach from this area because neurosurgeons are coming from the other side, from the sacral bone. And if you call a neurosurgeon inside the pelvis and you say him, please expose S2 and remove this schwannoma, maybe if you're lucky, you will know that is a uterus, that is a rectum, and it is. Neurosurgeons have no idea how to find the sacral nerve root inside the pelvis. But the general surgeon too. General surgeon who are doing rectal surgery every day, most of them don't know where you will find the sacral nerve root. So, now we are going in the field of the orthopedic, because orthopedists have exactly the same. You see, we had a patient that is a procedure for 6 years. It was a patient 3-4 weeks after a vaginal delivery, had a huge osteochondrosarcoma, and for the orthopedist, when they are coming from behind, patient is losing more or less 10 liters of blood. 10 liters of blood, that means they are giving 30 conserve during the procedure, because orthopedists are coming from behind, so it's the same, they are getting bleeding before they reach the tumor. We use the laparoscopy, so we are cutting here the obturator's muscle because it was involved. We expose the sciatic nerve, we cut all vessels in order to avoid bleeding. We are passing here a GG saw between the different sacral foramen, and we cut the bone by laparoscopic way, this area, because the tumor was here. And you see, with the jojo, we are coming through the foramen. That means the patient was lying on the side, and when we are going here through the sacral foramen, of course, we are coming here outside the gluteal area, and the tumor is here. We make en bloc surgery, because osteochondrosarcoma is not like sarcoma of the uterus. If you remove R0, the tumor, you save the life of the patient. And we did it. She is living now since 5 or 6 years. You see the orthopedists are cutting here the bone from outside. They open, of course, all the bottom, remove the piece, that is the tumor, put a piece of knee in the area, because we had a big leg, in order to stabilize the pelvic. And here you see the piece of knee. You have the obturator's nerve, the different screw, and the patient is able to walk with crutches. So that is laparoscopic neurosurgery, pelvic neurosurgery, or orthopedic surgery. And we have the Lion procedure. The Lion procedure is for laparoscopic implantation of neuroprocedure, because in neurosurgery there is a big field for neurofunctional surgery. You know, the deep brain surgery, again tremor. Neurosurgeons are using stimulator, electrode for different pain, for headache, for tremor, for epilepsy, but you can use also pacemaker within the pelvis to treat overactive bladder, to treat urine incontinence, and to treat some complaint in paraplegic. So the first thing we did is to use an electrode by laparoscopy tangentially to S2, S3, S4, because we wanted to prove at that time that to stimulate all nerve involved in the pudendal nerve, S2, S3, S4, is giving much better results than only one sacral nerve root as in interstim treatment. The next treatment, the next way then, was not to put the electrode on the sacral nerve root, but to put the electrode on the pudendal nerve, because we know that with the stimulation of the pudendal nerve, you may treat bladder overactivity, bladder incontinence, urinary incontinence, fecal incontinence, and some trouble with fecal constipation. So here you see how the way to do that. We are doing that in ambulatory. The laparoscopic exposure of the pudendal nerve take about 10 minutes, no more. It's just a question of anatomy. You've never been there, I suppose. But if you know the anatomy, it's not a big deal. You're outside the external iliac arteria. You have here the tissue, the lymph tissue. When you are following the psoas muscle, you will find the obturator's nerve. You're going further down, you will find the lumbosacral trunk. And when you follow the lumbosacral trunk distally, you will find the sciatic nerve. And at the caudal border of the sciatic nerve, you will find the pudendal nerve. So there are some vessels connecting the external iliac vessel to the psoas and to the iliacus, and here the internal obturaceous muscle. Here you have in the back the sciatic nerve. Just take care with this small vessel, not very, very dangerous, but if you cut this vessel, you will have a bleeding and you lose your vision. Here, in this case, we are in the back behind my device, the pudendal vein. We are just using bipolar coagulation. You cannot use monopolar device on any device that induces a high temperature, otherwise you will have a neuropraxia. So here you have the sciatic nerve. We have exactly here the sciatic foramen, the great sciatic foramen. And when you dissect the lower part of the caudal part of the sciatic nerve, you found here the pudendal nerve, just where the pudendal nerve is going below the sacrospinous ligament. So there is no need of huge dissection. And you will use the sacrospinal ligament to just put the electrode in direct contact. Here you have the pudendal nerve. Here we are coming from outside. We have already in the Eisen, the Internal Society of Neuropelviology, we have already a multi-centric prospective study. The boss of this study is Vito Chiantera from Italy. And here you have your electrode, and you can start to stimulate the pudendal nerve. But there is something much more interesting. Much more interesting is when you follow, because we start at the level of the sacral nerve root. The second step was to go to the pudendal nerve. And now the next step is to go to the dorsal nerve of the penis. And that is very interesting, because it's really easy to reach this nerve by opening the bulge, the radius, the space of radius. You never saw this nerve because you never look for this nerve. But when you open the radius on the left, on the right, it's easy to find behind the fascia the dorsal nerve of the penis. And when you put an electrode at this place, it's very interesting, because you have the dorsal nerve of the penis. You can treat bladder overactivity, fecal and urinary incontinence, but something more, something very important. Here you have, behind you have here the pelvic splanchnic nerve. The pelvic splanchnic nerve en parasympathetic nerve. That means when you put electricity on this nerve, you will induce an erection. And when you, with the same electrode, put electricity on the pudendal nerve, you will have a sustention of the erection. You understand what I mean? So, now, 2003, I performed my first line procedure in paraplegic. It was a colleague, Professor Rabichon from Montpellier, the father from Benoît Rabichon, who is working in Clermont-Ferrand. Benoît Rabichon is member, not only faculty, he is one of the founders of the Internal Society of Neuropelviology. His father was chef from the anatomy in Montpellier and asked me, 2003, Mr. Possover, can you put an electrode on the femoral nerve in a paraplegic for recovery of the motion? Few years later, I performed a Brindley implantation that were electrode for recovery of bladder function in this woman. She was the first paraplegic I performed a surgery. Something is wrong. Yes. So now, for paraplegic, we are using the Lion procedure, but the nerve we need on the femoral nerve is the nerve for the extension of the knee. The sciatic nerve is for the stabilization of the pelvis, stimulation of the gluteal muscle. And the pudendal nerve you need for recovery or control of the overactivity of the bladder in paraplegic. Here you see some picture from the first I did on the femoral nerve, and we put such a cuff electrode. That was the program SUA from Professor Rabichon. But now we are doing the laparoscopy, and I think that is really a great field for Da Vinci, for robotic surgery. And one of you guys, Semi Kidic from Houston, is neuropelviologist already. and he worked for 3 months in Aarhus, in the University of Aarhus, where I'm coming from, and he learned how to do the lion procedure of paraplegic. And he will start, hopefully, in the next few months in Houston with his surgery. And John Anderson from the Harvard University, we start, I don't know, but via Da Vinci or by laparoscopy. So when you put an electrode on the, as I told you, on the femoral nerve, you will have an extension of the knee. On the sciatic, you have a stabilization of the pelvis. Maybe the surgery make no big sense. Just to see the results. That is a paraplegic. I show you video just for fully, complete, total paraplegic. People sitting since more than 3-4 years in a wheelchair. And you see such a patient, I put an electrode, and now he's using this electrode to control, you see, I block the knee. It's not very nice, huh? It's not like you are walking, but it's just few months after the procedure. Now, what we know that from the literature, what we are doing that, when you put electricity on the sciatic nerve, if you take a look here, here you have the sympathetic trunk. The sympathetic trunk are involved in the vascularization of the lower extremity. And this sympathetic nerve are anastomosing with the sacral nerve root and are going through the sciatic nerve to the legs. That means when you put some electricity with a special frequency on the sacral nerve root, you will stimulate the sympathetic trunk and you will induce a vasodilatation, a peripheral vasodilation. And you will induce a neoangiogenesis to treat or to avoid decubitus, and first of all, to treat osteoporosis. Because paraplegics are suffering from osteoporosis. So if you put electron on a paraplegic and 1 hour later he tries to stand up and to walk, he will break his bones. So you have first to treat the osteoporosis. For this reason, we are putting the electrode and we advise the patient the first 3 to 6 months, you train, and you will start the walking, the staying up, just first 6 months after the procedure. So we treat osteoporosis and decubitus. Now something happened. We were not waiting on that. We were supposed to put electrode and to use the electricity, the stimulation of the nerve, as a robot. I put electricity and induce a motion. What we were not expected is that, what happened in this woman. You see, she has the control remote here. She is not using the control remote. She put electricity, and now this motion, she is a complete paraplegic. And this extension of the leg, she is doing by her own voluntary, with her brain. And that is exactly what we were not expecting. We are putting a program A with a lower frequency. Lower frequency is very painfully normally. And we put this lower frequency with the idea, if I put a low frequency electricity on the nerve, I will induce pain. And the job of the nerve is normally to bring the information to the brain. So I oblige the nerve to pass somewhere the spinal cord injury and to reach the brain. And obviously, it's exactly what happened in this woman. And now, you see some of our patients. You see on the left, I hope it will work. Here, that is our record man. He's a TH paraplegic. He's going now 2.4 kilometers this way. This one is a tetraplegic. He has the lesion at that level. That's the reason if you see the hand on this way. He's a tetraplegic, not a paraplegic. Maybe we can go a little bit forward with the video. Vous pouvez avancer la vidéo, s'il vous plaît. That is the nervus femoralis. We are doing the laparoscopy.
Marc, il y a quelqu'un qui peut le faire. C'est pour avancer la vidéo.
Ah oui. The procedure take about 1.5 hours to put all 4 electrodes. Voilà. Also, we need about 1.5 hours for the procedure. Of course, the patient is going home the next day because he's a paraplegic. He's no pain. Here we have a special patient. It's a patient we make the paper, you will see after, in nature spinal cord. In nature spinal cord, why? Because this patient was a flaccid, complete paraplegic. Flaccid, that means he didn't have just the lesion at the level of the spinal cord, but below everything was destroyed. So for this patient to be able to make this motion, you need reconnection from the spinal cord to the muscle. And now you see what I show. He's doing that with his own voluntary. That means this patient develop a reconnection somewhere between over and below the level of the spinal cord lesion, and develop a full reconnection from the spinal cord to the muscle. That means a recovery of the sciatic nerve and on the femoral nerve. And to the best of my knowledge, that is the first time that a complete flaccid, not spastic, flaccid paraplegic is able to do that. And what is very interesting is when you make an MRI, every neurosurgeon will tell you there is no chance for this guy to recover the gait function again. So something happened. We don't know really. Oh, sorry, maybe I want to see another woman. It was a lady suffering from a double lesion. So, and then I will be finished. A lady suffering from a double lesion. She had a cervical lesion, incomplete, and a thoracic lesion, complete. She had a scoliosis because of the accident. You see the left leg was completely disconnected from the body. She was paraplegic. That was her position. We did the laparoscopic implantation of prosthesis, and exactly the same happened. Something happened that this lady is today able to go this way. And that was 1.5 years after the procedure, and now she is going this way. So she recovered control of the trunk muscle, and she recovered trunk control on the legs. So something happened. If the connection is made inside the spinal cord, or by using the nerve around the spinal cord, or maybe there is a kind of lighting phenomenon. Thanks to the electricity use the brain information to pass the lesion. Or you have not to forget what is surrounding the spinal cord. Cerebrospinal fluid. And there is cells in cerebrospinal fluid. Maybe the information is or the electricity is using the cerebrospinal fluid to pass the information. We don't know today. We have a prospective randomized study already in Aarhus. Nucilio Lemos finished his study level 2 in Sao Paulo. He is now in Toronto. From my side, we have now 18 patients able to stand up and to walk. So you see the field of the neuropelviology, no dupe, is the field of the future. Because if you see in the past, we had this $6 million man. It was a movie for 30 years when we were young. It was maybe a joke at this time, but we're already coming in this area. And if you see the development today, the technology is outside the body. That on the glasses from Google. Now we are putting the electricity, the technology inside the body. And maybe we are in the beginning of a very nice story, because we have with stimulation, erection, ejaculation, bladder function, bowel function, leg function, and maybe when you put electrode in other part of the body, in the arm, somewhere else, you can have recovery of other function. So we are, I'm sure, at the beginning of a new story. Just few words on the International Society. You see here you have Benoît Rabichon, and we have an international faculty. He is Sami from Houston, who will start with Da Vinci. If you want to become a neuropelviologist, you have 3 very hard steps to absolve. The first, you have to absolve the e-learning course with the exam. You can do that home in order to learn the pelvic neuroanatomy and how to do the diagnosis. Then you have to absolve an Eisen level 2. That means it's a workshop with dissection of the pelvic nerve, lion procedure. Actually, you have 2 workshops in Aarhus, in Denmark, and in Zurich, in my department. And then you can come to us and to achieve the level 3. So to perform such kind of surgery. There is already a book where we have an internal society since 3 years. We have a book, we have the e-learning program, how to learn that. You do that by your own. We have the workshop. Here we are dissecting a sciatic nerve on the right side. We have now chapter more or less in all countries. Just few countries we don't have, but we have chapter of the Eisen in Australian, in Thailand, and we have on the other side, we have 3 teams in the US, and I thank you very much for your attention.
The first question maybe, in oncology we have a lot of problems, as you know, pelvic damage with pelvic pain, or urinary retention, for example, or incontinence. What do you think about that and the different possibilities, please?
I think it's simple. It's the first stage of the step of the neuropelviology to learn the pelvic neuroanatomy and to spare the nerves. In endometriosis, deep endometriosis, you cannot spare the nerves. When you have a parametric endometriosis and you will cut the parasympathetic nerve and of course the sympathetic nerve. But in oncology, you cannot spare the sympathetic nerve that are located in the middle of the pelvis, but the splanchnic nerve you can and you have to preserve. And the easiest way is to expose the sacral nerve root, S2, S3, S4, and when you follow the route, you will find the splanchnic nerve. And then it's easy, don't go there. I'm doing still the Schauter procedure, laparoscopic lymphonoidectomy with Schauter procedure. My patients are going home on the Thursday without any catheter. And concerning the lesion of the nerve, don't worry, not the oncologist on inducing the most lesion of the pelvic nerve, but the urogynecologist with mesh, especially in the dorsal part of the pelvis. Secondly, the surgeon, because surgeons are doing a lot of rectopexy and they're putting stitch to the sacral nerve roots.
Very nice presentation, very amazing. One question: you put electrodes to stimulate to stimulate the nerves, but after a while there is a reaction of healing. And do you have to change your electrodes, or is there anything that compensates the use of these electrodes?
That is exactly the point. Because when I start with the neuromodulation in bladder disorder, it was after failure of the anti-stim therapy, the sacral nerve stimulation. At that time, we saw that when surgeon or urologists are putting an electrode from behind through the sacral foramen, but the screws, they are not in direct contact to the nerves. There is some tissue in between. So in the beginning, they are putting electricity, no problem, it works. And after 6 months, 1 year, the patient will develop fibrosis surrounding the electrode, and the patient will have to increase the voltage or the ampere of the stimulation to reach the nerve for the same effect. And at one level, this stimulation will get painfully. And that was the idea with the laparoscopy, because if you want to avoid this phenomenon, there is only one way, the way of the neurosurgeon. The electrode have to be in direct contact to the nerves in order to not let the body to develop fibrosis between the nerve and the electrode. And that's the reason in the beginning we were putting the electrode around the sacral nerve root. When you put the electrode on the pudendal nerve without cutting primarily the sacrospinous ligament, the ligament will push your electrode in direct contact to the pudendal nerve. And at the level of the reduced space, that is not a problem. In paraplegic, it's not a problem at all because we are using another electricity. So my first paraplegic, the guy who is walking 2.6 kilometers, he have a device, a rechargeable one, and I performed the surgery, it was 2010. So you have to be in direct contact to the nerve, that is the key.
Marc, just a simple question. If you want to have access, for example, to remove a schwannoma from one of the roots of the sciatic nerve, you will approach from lateral, as we saw it in the pudendal, and just cut some branches to the gluteal or wherever, or you will come from medially of the big vessels and cut there the vessels to have free access.
Normally I started from laterally, but when you have a schwannoma like we saw from the femoral nerve, you will have to come also from medially. Because if you're just coming from laterally, you will have too much distortion from the external iliac vessel with risk of thrombose and so on. So I make a window medially to the external iliac vessel. So I have one forceps coming from laterally and one forceps coming from medially. And the optic usually is coming from laterally. So I'm not touching or compressing the external iliac vessel during the procedure. Okay. But it's really important to go laterally to the lymph node and to go laterally to the obturator's nerve and vessels in order to not induce a lymphoid cell. And lymphoid cell should be a big problem when you put an electrode. When you have a lot of fluid, you will reduce the efficacy of the stimulation. So you have not to remove, to touch the lymph node. Just put them away.
Okay.
Other question? Many thanks.
If I have a message for you, when you have a patient with deep endometriosis from the pelvic sac wall, always ask the patient if she has some sciatic pain, and you will have a surprise. It's much more frequent you think. Sorry.
Just following from that, how do you diagnose then? Sometimes they have laparoscopy and you think the endometriosis isn't that bad, but if they're going to have deep endometriosis of sciatic nerve, femoral nerve, what do you do for diagnosis before you decide to operate on that?
The diagnosis in neuropelviology is a clinical diagnosis. By the SLU, you make your diagnosis by the patient history. So in neuropelviology, we're unlucky because most of the patients have no idea about that. You have sometimes patients coming in our office, they read a lot about the pudendal nerve or the obturator's nerve, so they are explaining a story. But when you have a patient who come and said, yes, I have pain, so the typical deep infiltration, infiltrating endometriosis of the sciatic nerve, if in the upper part of the sciatic nerve. So he always go inside the sciatic nerve at the level of the lumbosacral trunk. When you have endometriosis, parametric endometriosis at the level of S2, S3, S4, usually the endometriosis only surrounds the nerve, but grows inside is L5, S1. So it's typical. You have a patient L5, is a pain lower back, bottom, and going laterally to the thigh, and in the front of the, below the knee, going here in the front, externally, and S1. S1 is going here, and L5, S1, you have no pudendal fibers. So the patient have no pain going to the pudendal area, and the nerve of the bladder are coming from S2, S3, S4. So the patient have no overactivity or hypersensitivity of the bladder. And then, when you see that, it's clear when the patient said during my men's bleeding is even worse, but also outside. And it's incredible because endometriosis of the sciatic nerve don't need 10 years to grow. After 6 months, at least 1 year, the patient will develop terrible pain. And when you have an infiltration of the lumbosacral trunk, you will see the patient will come in your office this way. Because S1 is the Achilles reflex, so the patient, when you have a lesion of S1, patient will not have a plantar flexion, and L5 is the contrary, is a dorsal flexion. So the patient is not able neither to do that, nor to do that. She cannot both. She have no flexion, dorsal and plantar. So the combination of all information will say, yes, the patient is saying the right. And when you go with your finger in the vagina, you go to the sacrum, and then laterally, and you will have a trigger pain. And trigger pain in neurology is a typical sign, what we call the Tinel sign. Tinel signs, that mean when you put the finger of a nerve that is irritated, the patient will feel an electricity, a pain, going down distally to the nerve. So you put your finger and the patient will say, wow, pain is going down, and you have your diagnosis. You can make an MRI if you want, but you have to do the procedure in any case.
Many thanks, Marc.